What's up, Ninja Nerds? In this video, we're going to talk about how to systematically approach a 12-lead EKG and have a master interpretation of it. Before we start that though, let's start talking about the basics of EKG, the foundational concepts that you need to have in order to effectively and efficiently read 12-lead EKGs. So what do I need you guys to know first? The first thing is, when you look at an EKG, they have all these different deflections and blips up and blips down and flat lines. What do all these things mean? We should have a basic idea of that. Straightforward, the first positive deflection or blip here is called your P wave. The P wave is indicative of atrial depolarization. So you have a structure here called the SA node in the upper part of the atria. What happens is it intrinsically depolarizes, generates action potentials that spread throughout the atria. That electrical activity that's spreading throughout the atria from the SA node is represented by the P wave. The next part is at the end of the P wave until you get to the QRS complex, there's this flat line. It's called the PR segment. The PR segment is the time period where all those electrical activity that was coming from the SA node throughout the atria all converge and come onto the AV node. So the AV node gets hit with that depolarizing wave and holds on to the electrical activity, but doesn't send the electrical activity down into the ventricles yet. It just holds on to it. That PR segment is indicative of AV node depolarization. Now, let's add on to that. If you take the P wave, which is indicative of atrial depolarization, and you take the PR segment, which is indicative of AV node depolarization, combine those two together, you get the PR interval, which is the time span from which the SA node fires, depolarizes the atria, depolarizes the AV node, and it's just getting ready to send those action potentials down to the ventricles. Got it? Next part. You have this down portion here, up portion, down portion, and then back to a flat line. This thing right here where you have the down portion, this is called the Q of the QRS complex. This one up here is the R of the QRS complex, and this one is the S wave or component of the QRS complex. What is it indicative of? Ventricular depolarization. So, follow back, the AV node is depolarized. Finally, it said, hey, ventricles, take the electrical activity, sends the electrical activity down through the ventricles, they depolarize, and what do they generate? The QRS complex, so indicative of ventricular depolarization. After the QRS complex, you have this S wave. Right after the S wave, it goes up and then goes into this flat line. This here is called your ST segment. The ST segment is indicative of still ventricular depolarization, but there's no net direction, there's no net movement or electrical activity in a particular net direction. It's just the ventricles are depolarized, they're holding on to that positive charge, and they're just getting ready to repolarize. Okay? There's no net movement of electrical activity, no particular vector being directed. It's just the ventricles are still depolarized, waiting to be repolarized. That is the ST segment. The next part here is this next positive blip. The next positive blip is called the T wave. The T wave is, remember, what would we end off with? ST segment, right? That was the ventricles are depolarized still, but they're just getting ready to repolarize. What do you think the T wave is indicative of? Ventricular repolarization. So finally, the ventricles go from positive to a negative charge, and they create this upward deflection called the T wave. The last part of this EKG that I want us to talk about is what's called the QT interval. So the QT interval, it starts right here, right before you have that Q wave, right? So just as we get ready to go at that downward deflection, all the way until after the T wave. That is the QT interval. It's indicative of the time period where the ventricles are depolarized and repolarized. Very important later when we talk about prolonged QT intervals, okay? So I think that gives us a big idea about the different components of an EKG, particularly the waveform, and what that tells us about the electrical activity of the heart. The next thing that you need to know is, how do we pick up the electrical activity of the heart? How do we register that on an EKG paper or an EKG graph? We utilize things called electrodes. And electrodes, there's a bunch of different types, and we use these different things called leads to determine the electrical activity of the heart in different planes. Let's talk about that. So here we have some hearts, and we're going to focus on a particular electrical activity in a very specific portion of the heart, and what leads, which are going to be based upon the electrodes where we put them, what leads tell us about the electrical activity in that portion. So for example, the inferior part of the heart, which tells us a little bit about the right ventricle, a little bit about the left ventricle, leads 2, 3, and AVF are going to tell us about that part of the heart. Very important when we start talking about things called STEMIs, ST segment elevation demise. The next one is if we're talking about the lateral ventricle, the lateral wall of the left ventricle, okay? This whole portion is, the electrical activity in that part is told to us by what leads? 1, AVL, V5, and V6, okay? Next is the right ventricle. The right ventricle, the electrical activity in that part of the heart is told to us by what leads? V1, V2, and AVR. Last but not least, the anterior portion of the heart and the septal portion of the heart is told to us by what? The electrical activity in that part of the heart is told to us by what leads? V1 to V4. To quickly recap what all of these things mean, we have 12 leads. Where does that 12 leads come from? We have 3 bipolar limb leads. Lead 1, lead 2, and lead 3, okay? We have 3 augmented unipolar limb leads. That's AVF, AVL, and AVR. And we have 6 precordial chest leads, which are going to be V1, 2, 3, 4, 5, and 6. That's where we get the 12 particular leads that tell us about the electrical activity of the heart for our EKGs. Now that we have a basic idea about the electrical activity, what that tells us about the heart, the different electrodes and leads that tell us about where the electrical activity is occurring in the heart, let's talk very, very briefly about the basic things that we need to know about an EKG strip. All right, so the last part that we need to understand is when you look at a 12-lead EKG, there's all these boxes, right? And there's a big box and there's a bunch of boxes inside of it. What the heck is that for? What you need to know is that you have a big box, and then inside of that big box, there's a bunch of little boxes, right? One large box is about 5 millimeters in height. It's about 5 millimeters in width. Why is that important? Well, you should know what the height is telling you, and you should know what the width is telling you. Height is telling you about amplitude. It's telling you about voltage, how much electrical activity that these different parts of the atrium ventricles can generate. And the width is telling us about time. How long is it taking for this electrical activity to move through the different portions of the heart? Why is that important? We'll talk about that later as we go through our systematic approach. But what I want you to know is to have some numbers in your head, not so much the height, but just for the thoroughness sake, 5 millimeters of the large box is equivalent to 0.5 millivolts. What I really want you to know is 5 millimeters in width is indicative of 0.2 seconds of time that electrical activity is taken to occur. And the same thing, if you take a big box, there's 5 little boxes that are going this way and 5 little boxes that are going up this way. There's about a total of 5 raised to the second power, 25 little boxes in one big box. If we take one of those 25 little boxes and zoom in on it, what do we need to know about that? Same thing that we need to know about the large box. Its height and its width. Height is 1 millimeter, width 1 millimeter. So 1 millimeter of height tells us that this is equivalent to 0.1 millivolts, all right? And more importantly, is 1 millimeter in width is indicative of 0.04 seconds of time that has occurred within the electrical activity of the heart. These are the basic things that we need to know to be able to effectively and efficiently read 12-lead EKG systematically. Now let's go ahead and talk about the next part of our systematic approach, which is the rate and rhythm. All right, Ninja Nerds, in this video we're going to talk about how to determine the rate and rhythm on a 12-lead EKG. So before we start doing that, let's take a look here at this makeshift 12-lead EKG here and really quickly recap what we talked about in the basics. 1, 2, 3, those leads are what? Your bipolar limb leads. Tell us about the vertical plane. AVR, AVL, AVF are going to be your augmented unipolar limb leads. They tell us about the electrical activity in the vertical plane. V1, V2, V3, V4, V5, V6 are your precordial chest leads. They tell us about the electrical activity in a horizontal plane, right? Now, this is kind of what a 12-lead EKG should look like, right? We have all the different leads that we talked about, 12 total leads, and then we have a rhythm strip, which focuses on one of those leads and continues out for about 10 seconds in duration. Usually the most common one is lead 2. So this is what kind of a 12-lead EKG should look like. Now, how do we go about determining the rate of this actual 12-lead EKG and then the rhythm? Let's go through it. First thing I really want us to know is let's be simple, right? Keep it simple. Are we going too fast, too slow, or is it a normal rate? Well, I gotta know what a normal rate is. Normal rate is between 60 to 100 beats per minute. So if I'm less than that, that's bradycardia. If I'm greater than 100, that's tachycardia. How do I determine this though? There's a couple ways. One is usually on the printout of the 12-lead EKG, they can give you the rate. And for the most part, Those are usually accurate rates, other than if they have peak T waves. Sometimes that can track off the T wave in the QRS complex. But for the most part, the machine is relatively good at giving you a rate. But always make sure. How do we do that? There's two methods. There's the box method, and then there's the R waves times 6. So let me tell you the R waves times 6. It's a really quick, easy one. For example, if I take here my R waves, I take my rhythm strip. I only look at rhythm strips first. And I take and I count how many R waves I have in that 10-second strip. I'm going to count 1, 2, 3, 4, 5, 6, 7, 8, 9. That's 9 total R waves. I'm going to multiply that by 6. 9 times 6 is 54. So 54 beats per minute is about my rate if I'm utilizing that R wave times 6 method. Okay? So that's a little slow. I would kind of consider that maybe bradycardic. Okay? Let's use the other method, the box method. Now remember, this isn't perfectly to scale, okay? If we was perfectly to scale, it would be, it would work out perfectly, but all you're doing is you're measuring the distance between an R wave and an R wave on the number of boxes between. For example, if there's only one box between the R and R, that's 300 beats per minute. If it's 2 boxes, that's just 300 divided by 2. So that's 150 beats per minute. If there's 3 boxes, it's 300 divided by 3. That's 100 beats per minute, okay? So you can do it 2 ways. You can say, how fast am I going based upon the box method? How many boxes? Divided, it's 300 divided by the number of boxes. Or how many R waves do I have multiplied by 6? Okay. We've kind of used the R wave method here because we drew this out. So we said 54 beats per minute is about our rate. So we're kind of in the bradycardia range. Next thing we do, what's the rhythm? Is it regular or is it irregular? How the heck do I determine that? We look at our R to R interval. So what I would do is I would take like a little note card, and I would take the note card and I would make like a little line here and a little line there on my note card. And then what I would do is I would track the actual line to line and make sure that it's pretty much constant as I go the entire length of the rhythm strip. So that R to R interval that I mark on my note card has to be the same. If it's not the same, it is what? Irregular. If it is happening every single time I line that up on my note card, it is very, very consistent and constant R to R, it's regular, okay? In this case here, it's not going to be perfect, but we're going to say it's regular. Okay, so far we know that we're bradycardic, and we're going to say here that our R to R interval is constant, so it's regular. Next thing I need to determine, what's the QRS look like? Is it wide? Is it a big mama? Or is it narrow? Is it a little mama? Right? How do I determine that? Again, if I were to really measure this, and we will look at this on 12-lead EKGs, we measure how many little boxes are between the QRS complex here. If there is greater than 3 small boxes within that QRS complex, that is considered to be wide. So if you remember, how many seconds is one little box? 0.04 seconds times 3, 0.12 seconds. So if it is greater than 0.12 seconds, it's wide. If it's less than that, we consider it narrow or maybe even indeterminate. We'll talk about that later, okay? So in these, we're gonna say that that is narrow, okay? We're gonna say that they are less than 0.12 seconds or 3 little boxes. So far we're bradycardic. We have a normal interval, okay, R to R interval, so it's regular. We have a narrow QRS complex. Next thing, is there sinus P waves? What the heck does that mean? So I like to go to lead 2. This is how I learned how to do it. I look at lead 2 and I say, what's my P wave doing? Is it upright? I look here, my QRS complex, it has to be a P wave before the QRS. It is upright. Then I say, okay, my AVR has to be the exact inverse or opposite of lead 2. So let me go to AVR. Is my P wave retrograde or inverted? It is. So if my P wave is upright in lead 2, inverted in AVR, and go down to my rhythm strip, every P wave is followed by QRS, which it is. This is sinus rhythm. Okay? So far, what have I been able to assume? Bradycardic, normal, a regular constant, a regular interval, so regular rhythm. It's a narrow QRS, and it's sinus rhythm at this point in time. I can then determine my PR interval. So if you guys remember, that's taking the P wave and the PR segment and measuring that. I want to know, is it prolonged? Is it normal? In this case, we're going to say it is less than 0.20 seconds. It's going to be normal, okay? So we have in this case, bradycardic, regular, narrow QRS, sinus rhythm, normal PR interval. That is going to be a good way to pretty much systematically approach rate and rhythm. Now, let's say that we take this into consideration, we really take into consideration differential diagnosis, which is super important when a person is going too fast or they're going too slow, and utilize that system. Let's talk about that. All right, so let's use our system. All right, let's say we're taking a look at a 12-lead EKG. Is it going too fast, too slow, or normal? Let's say in this case, the person is going too fast. It's tachycardia. Next thing I want to know, is the rhythm regular or irregular? Okay, let's say it's regular. What's my QRS looking like? Is it wide or is it narrow? Let's say in this case it's narrow. If you go through that system that we just talked about, that should give you a differential for narrow and regular tachycardias. For narrow regular tachycardias, there's 3 particular things that you need to try to figure out what it is as a part of your differential. First one is sinus tachycardia. How can I determine if it's sinus tachycardia? Is there sinus P waves? Is there upright P waves in lead 2 that are inverted in AVR and a P followed by QRS? Atrial flutter and SVT, we'll talk about those a little bit later. They can be very difficult to distinguish. But these are the 3 things I need you to remember as a part of your differential. Next thing, is it tachycardic? Is it irregular? Is it narrow? There's 3 more differentials I really need you to remember. First one, most common, AFib. Are they in atrial fibrillation? Do they have variable block? So atrial flutter with a variable block. Whereas if you guys remember here, with narrow regular, it could be a 2-to-1 atrial flutter, and that produces a narrow regular tachycardia. But if it's atrial flutter with a variable block, that can produce a narrow and irregular tachycardia, okay? So AFib, variable atrial flutter, and multifocal atrial tachycardia should be your differential for narrow, irregular tachycardia. What if you're tachycardic, you're going too fast, you have a regular rhythm, but you have a wide QRS? Always, always, always VTAC, VTAC, VTAC until proven otherwise. Other things that it could be SVT with a bundle branch block, sinus tach with a bundle branch block, or antidromic WPW, but by far the most important, wide regular tachycardia, VTAC until proven otherwise. The next one here is what if I'm going too fast, irregular rhythm, and a wide QRS? Polymorphic VTAC, there's 2 types, normal QT and prolonged QT. Atrial fibrillation with Wolff-Parkinson's-White syndrome, that's a pretty serious one, and AFib with a bundle branch block. Last but not least, if we have a differential for bradycardia, you still follow the same sequence and systematic approach we did above. The only thing that's going to be a little bit different, we'll talk about these in individual cases, is that whenever I see bradycardia, I go through the same system, but I'm looking to break these into these groups. Are they having sinus bradycardia? Are they having an AV block? Is it a junctional rhythm or is it a ventricular rhythm? And we will go into great detail on these and really expand on this approach, particularly when we get to this 5th step here in our cases, okay? So this is really what I want you guys to remember to approach every EKG the same way in determining the rate and rhythm for a 12-lead EKG. All right, engineers, in this video, we're going to be talking about the ST segment and any particular abnormalities. Now, you guys may be wondering, Zach, why did we go straight from rate and rhythm right to the ST segment? Shouldn't we go through all the other parts of the EKG, like the different waves? You could, but here's the thing. You want to focus your time on a 12-lead EKG and what's going to probably kill the patient the quickest, right? What would kill someone really quickly? An arrhythmia. That's why we got to go through and determine the rate and rhythm. Is this person having a deadly arrhythmia? Then the next thing that can really kill a patient is if they're having any ischemia or infarction. And that's where we really got to take a look at those ST segments very carefully. Okay, so that's why we're going to focus on this next. So, ST segments and their abnormalities. Why do I need to know this? Well, the first thing that I need to know is there any ST segment elevation? And I go through each lead. I go all the way 1, 2, 3, AVR to AVF, V1 all the way to V6. And I look at that ST segment. Is it elevated in any of those leads? Well, here's the thing. How much elevation do I truly need to be classified as ST segment elevation? And does ST segment elevation always equal MI? Not necessarily. So let's talk a little bit about this. ST segment elevation, the way that you truly measure it is at the end of the QRS complex, there's a point called the J point. So if you could imagine here's our QRS. There actually is no S wave because an S wave has to come down through the isoelectric line and then come back up. But right there at the end of this QRS complex is that little point there that goes into our ST segment. That there is our J point. So you measure from the isoelectric line, which would be right here, how many millimeters above that isoelectric line until I get to the J point is there? If it is 1 millimeter of ST segment elevation in any of the leads, okay, except for V2 to V3, that's ST segment elevation. It has to be in 2 contiguous leads, but 1 millimeter ST segment elevation in any of the leads except for V2 to V3, that is considered to be true ST segment elevation. It has to be 2 millimeters of ST segment elevation in V2 to V3 in order for it to be truly ST segment elevation there as well. Okay, so 1 millimeter everywhere except for in V2 to V3 has to be 2 millimeters. Okay? If it is elevated, can we automatically say, oh, it's a STEMI? No. There could be a plethora of differentials to be considering. On the top of the list, though, should be STEMI. Some of the difficult things to sometimes really deduce is this person having a STEMI, or are they having benign early repolarization? We'll have some good cases on that. Are they showing signs of pericarditis? Do they have Prinz-Metals angina, also known as vasospasm? Are they having a PE, a pulmonary embolism? Is there a left ventricular aneurysm? Is there left ventricular hypertrophy, or is there a left bundle branch block? And we'll actually have a pretty good conversation about left bundle branch blocks in the setting of a STEMI, and we'll talk about Scarbosa's criteria for that. But we're going to try to go through a bunch of EKGs to figure out, oh, we see ST segment elevation. Which one is it? If you don't think about it, you can miss it. So always have a good differential and rule every single one of them out effectively. This is what we need to know about ST segment elevation. Now, just as important as ST segment elevation is what if those ST segments are sagging a little bit? They're depressed. That's also very important. Okay, there's 3 different types of ST segment depression I want you guys to be thinking about. One is where you see it here, we have this ST segment, it's kind of like sagging a little bit, and it's kind of like downsloping a little bit. If I were to draw a tangential line, it's gonna look like it's going this way. That's downsloping ST depression. If I had a line here, that's horizontal ST depression. And if I have this one here, a tangential line, that's upsloping ST depression. Now, ST depression is just like we would say with ST elevation. Find your J point. Where's my J point? Here's my J point for this horizontal one. I want to know with respect to my J point, here's my J point, how many millimeters, how many small boxes is that J point below my isoelectric line? If it is greater than or equal to 0.5 millimeters, that's almost like a half a little box. If it is greater than that in 2 contiguous leads, and this is in any lead, that is considered ST depression. Now, out of all of these, is there one of them that we should be more concerned with? Actually, yes. Horizontal ST depression can be a harbinger for actually concerning signs of ischemia. So always, if you see someone with ST depression and you see horizontal ST depression, do not send them home because this could be a sign of ischemia. The next thing though is to don't actually kind of like say, well, what about upsloping? That one's not that big of a deal and downsloping's not that big of a deal? Not necessarily true. Upsloping ST depression, there's a newer thing called the De Winter's T-waves criteria, which is almost a STEMI equivalent. If you see someone who has ST depression in V1 to V3 with peak T waves, this can be a harbinger of a very proximal LAD occlusion and a very scary type of STEMI pre-coming. Okay, so be thinking about that. ST depressions, what do I need to know? Greater than or equal to 0.5 millimeters below the isoelectric line to the J point is ST depression by definition, and what could that tell me about? And STEMI should be at the top of the list. Okay, very important one. But another big one to think about is a posterior MI, especially if you have ST depression with upright T waves and dominant R waves in V1 to V3, think about posterior MI. We'll go through a bunch of these cases. The other ones to be thinking about is left bundle branch blocks, left ventricular hypertrophy with strain pattern. Another really big one, very important when it helps to determine is this person having a true STEMI, is you can see ST depressions when someone's having a STEMI, and these are called reciprocal changes. And the last one is a drug called the digoxin toxicity, and actually produces a very classical type of U or sagging type of downsloping ST depression. And we'll show you some of those as well. All right, the last thing that I want you guys to think about, and this is the only reason I threw it with the ST segments is it's going to become very helpful. We'll talk about it later. We use this when we're trying to determine benign early repolarization from STEMIs, and I'll show you what I mean. But is the last thing I want you guys to talk about is a J wave, sometimes also referred to as an Osborn wave in the setting of hypothermia, but also hypercalcemia. We'll talk about what I mean there. But usually it kind of takes on this kind of like fish hook pattern. So you have your Q wave, your R wave, and then you're coming down. You don't actually have an S wave, because again, what does the S wave have to do? It has to go down through the isoelectric line and come back up. So you don't actually have an S wave. It stops here, so it's kind of like the downslope of the R wave, and you get this quick little blip, and then you go into the ST segment and then to the T wave. That little blip right there is called your J wave. Okay, so this little blip right here is called your J wave. Why is that important? If I have someone who has ST segment elevations with a visible J wave, in particular leads, and we'll talk about this later, this could be an indicator of benign early repolarization rather than ST segment elevation MI. Okay? So again, what is a J wave? It's a quick little short positive deflection on the downstroke of the R wave. Okay? And it's going to be very helpful later when we're trying to differentiate benign early repol from a STEMI. Okay? But to be thorough, because again, if you don't think about it, you can miss it. J waves can also be seen not just in benign early repol, but in hypothermic cases and hypercalcemia and a super rare condition called Brugada syndrome, where they have ST segment elevations, right bundle branch blocks as well, and sometimes a visible J wave. Okay? Very rare condition though, but if you don't think about it, you can miss it. Why am I going now to T wave? So we start off talking about rate and rhythm. Why? Because we need to know if there's any arrhythmias that can definitely kill a patient very quickly. Then we talk about ST segment. Is there any ischemia and infarction? Right? Why is that important? Because if someone's having an MI, that could also kill them. But here's another big thing. Always look at the T waves as well. Any abnormalities in T waves, particular types, could also be a sign or a harbinger of impending ischemia or infarction. So that's the next thing we're going to look at. The big one that I really want you guys to remember is T-wave inversions. Now, T-wave inversions are classified as when you have, technically, the T-wave has to have kind of this deflecting or depression in a way that has to be at least greater than or equal to a millimeter below that isoelectric line or point, okay? So that's the first thing. Now, you can have T-wave inversions that can be considered completely normal if they're in V1, V2, your precordials, or in lead 3. That's fine. Where am I most nervous? If I see a T-wave inversion by itself, just by its lonesome in AVL, I'm going to keep getting serial EKGs because you want to think about that. That could be a sign of impending inferior wall MI. Okay, think about that. Here's the other thing though. Think about your differentials with the T-wave inversion. Yes, it could be a sign of ischemia. What kind? It could be potentially an inferior wall MI, or if you have these T-wave inversions that are in V2, V3 sometimes, this can be a sign of the Wellens B criteria kind of type of ischemia. Is that something to be thinking about with approximate LAD? But other things to keep in mind for your differential is there any left ventricular hypertrophy with strain? Is there any elevated intracranial pressure, sometimes called cerebral T waves? Is there any bundle branch blocks, left bundle branch block, right bundle branch block? Is there any pulmonary embolisms, right? Sometimes you see this with an S1Q3 T3 type of pattern. We'll talk about that. So big things to be thinking about when you see T-wave inversions. But again, this is that big one. I really want you guys to remember that AVL, okay? The next one is the hyperacute T waves. Hyperacute T waves, very tall, okay? Broad-based, asymmetrically peaked if you look at that. So it doesn't have that beautiful kind of concave type of pattern that you'd usually see with it. So hyperacute T waves, another way that you want to think about them, if you can take your QRS complex and almost fit it into that hyperacute T wave, that is also a sign that it's probably a hyperacute T wave. So again, broad-based, tall, asymmetrically peaked, maybe you can even fit the QRS inside of it, hyperacute. Why is that concerning? Hyperacute T waves definitely can be a sign of an early STEMI, especially, here's a very, very important one. We'll talk about these when we get to look at the cases, but if I see that T wave, again, normally you kind of want it to be concave, but if it starts to look flat, like almost straight as I'm going towards the upper slope of the T wave, that is a sign of early ischemia, okay, a little bit concerning. But the other thing to be thinking about is vasospasm, so Prinz-Metals angina. The next one is a biphasic T wave. Biphasic T waves are, again, something you want to be thinking about. Little scary if I see these in V2 to V3. Okay, the reason why is that kind of fulfills this Wellens A criteria, which could be a sign of a proximal LAD occlusion. So if I see an upward blip and then a negative blip, I'm thinking about Wellens A, especially if it's in V2 to V3. If I see the opposite though, where I see a negative blip and then a positive blip, I got to be thinking, maybe this could be hyperkalemia. So check the potassium, see if that's a little elevated. Okay, so biphasic T waves, think about those two types of things. The next one is a flat T wave. Flat T waves, we have to kind of fit within the line of depression and normal, right? So we say depression is greater than 1 millimeter below the isoelectric point. So a flat T wave has to be somewhere at least, you can go up to less than like -1 millimeter of depression and a millimeter of elevation, or a positive deflection there. So it has to be between -1 millimeters of deflection downwards and a millimeter of deflection upwards. Okay, that's a flattened T wave. Flat T waves, definitely a sign of impending ischemia. Definitely got to be concerned about those. And also hypokalemia, check their potassium. All right, the last one that I want to talk about here is peak T waves. Okay, peak T waves, they look like they would hurt to sit on, okay? So these are very narrow-based, very tall, and for the most part, they're relatively symmetrically peaked, okay? So if I see a peak T wave, obviously the first thing that comes to mind, and everybody, they would say, oh, hyperkalemia, definitely could be. Also could be hypermagnesemia, definitely could be. One thing I really want to be thinking about though, which is becoming a very big thing, is the De Winter's types of T waves. So this is actually considered to be a STEMI equivalent. If I see peak T waves in V1 to like V3 area, and I also see an upsloping ST depression, I'm going to be a little bit scared for a proximal LAD occlusion. That's called the De Winter's T waves. So be thinking about that. Yes, peak T waves definitely can be hyperkalemia, could be on the lower end hypermagnesemia, but if you see this in V1 to V3 with an upsloping ST depression, be concerned for De Winter's T waves, which could be a proximal LAD occlusion. Why are we going to the QRS wave? Well, what have we covered up to this point? We talked about the rate and rhythm. We want to know, is there any arrhythmias? Why? Because those can kill a patient very quickly. Then we went into the ST segment. Is there any ischemia? Is there any infarction? That's also a very scary thing. Then we look at the T waves. Why? Because the T waves could be sometimes an early sign of ischemia or infarction. Now what we're going to do is we're going to talk about the QRS complexes, and we want to know a couple different things about them. What do we want to know? Well, the first thing that we want to know is, going back to our original thing from the rate and rhythm, is the QRS complexes wide or are they narrow, right? That's important. Remember what we said for a wide QRS? We said basically if it is greater than 0.12 seconds in width, which is 3 small little boxes, that is considered to be a wide QRS, right? Remember I told you though that sometimes if it's between 0.10 to 0.12 seconds, it's kind of like, we're on that teetering part of it being wide, but it's not, so it's kind of like an indeterminately wide QRS. But let's just be simple, greater than 0.12 seconds, it's a wide QRS. That's what we're going to stick with. But just to be very, very thorough, just remember that there is an indeterminate point. Okay, if I see a wide QRS, what do I need to be thinking about? You got to have a differential. You don't think about it, you'll miss it, right? What do I think about? First and foremost, bundle branch blocks. Is there a left bundle branch block, a right bundle branch block? And we'll talk about the patterns that you can see with those in a second. The next one, hyperkalemia. Hyperkalemia can show up as anything anymore. You know, you don't always think it's going to, you think it's going to show up as a peak T wave, but sometimes it'll show up as a wide QRS complex, sometimes as a junctional rhythm, so always be thinking about that. Again, hyperkalemia, you see a wide QRS, think about it. What did I tell you always to think about with a wide and regular type of tachycardia? VTach, right? So if I see a wide QRS, I also want to be thinking about VTach. Another one though that was in that differential of wide, regular tachycardias was what? WPW, right? But particularly we call it antidromic WPW. So another one that you can think about. Again, if you don't think about it, you could miss it, even though it might not be super common. The other one is a pace rhythm. So if someone has a pacemaker, paced rhythms can sometimes produce wide QRS complexes. So think about those as well. And last but not least, medications always have in the differential tricyclic antidepressant overdose as a potential for wide QRSs. So wide QRS, you see it, you by greater than 0.12 seconds, 3 small boxes, there's your differential. Make sure that you rule those out. Really quickly while we're here, bundle branch blocks, okay? You want to be able to identify these on the 12-lead EKG, and we're going to look through a bunch of these. But left bundle branch block, when I look in V1 and V2, what I see is I see that my S wave is really, really big. I get this deep S wave there. And then when I look in V5 and V6, I see this positive deflection with a little divot, kind of almost making like a little M, if you will, in V5 and V6, okay? So that is definitely very important. Left bundle branch block, look at V5, V6, you're gonna see kind of like this almost M type of shape with that actual QRS complex. For right bundle branch blocks, when I look in V1 to V2, you have this characteristic R, S, R prime pattern that you see in V1 and V2. And then in V5 and V6, you have your R wave coming down into your S wave, but look how wide the S wave is. There's a slurring of the S wave in V5 and V6 for right bundle branch blocks. Okay? So that's a big thing to remember. For left bundle, you see kind of this M-shaped, very wide QRS in V5, V6, deep S wave in V1 to V2. Sometimes you even get a little bifid kind of formation in V1 to V2 in that S wave. You might even get a little bifid, just like you see here in V5, V6. All right, that's our bundle branch blocks. The next thing that I need you guys to understand, besides wide QRSs, what else could be very significant to pick up as an abnormality, is pathological Q waves. Now you guys are like, wait, I thought Q waves were a part of the normal QRS complex. They are, but you shouldn't see them in particular areas on the 12-lead EKG because they should not be there. That could be a sign of ischemia or old ischemia or other negative things. So we never see them in V1 to V3. If you ever see them in V1 to V3, Q waves, it's not normal, regardless if they're small or they're actually considered pathological. Regardless, you see a Q wave there, not normal. What do we consider to be a pathological Q wave versus a normal Q wave? A pathological Q wave is it has to be very wide. So if you were to measure that kind of distance there of the Q wave, it would have to be greater than 0.04 seconds, which is a small little box. Or from the isoelectric line down to the peak of the Q wave, it has to be 2 millimeters deep. Or if I measured the distance from the isoelectric line down to the bottom of the Q wave, and then I measured the height of the QRS complex, if that Q wave is greater than or equal to 25% of the height of the QRS complex, that's also considered to be a pathological Q wave. Why is all of this important? Big thing is MIs. Okay, sometimes this can be a sign of a new acute MI or someone had an old MI in the past. Okay, so these sometimes can actually occur acutely and they stay along for a very long time. Okay, but also be thinking about PEs with that S1Q3 T3 type of pattern. Think about left bundle branch blocks. They can definitely produce pathological Q waves, and LVH with a strain pattern. Okay. All right, so the next one that I want to talk about is low voltage QRS complexes. These sometimes can be kind of overlooked. And for the most part, they're not too serious in the particular clinical setting. But if I see someone who is short of breath, they're tachycardic, I got to be a little bit concerned for a pericardial effusion, right? So how do I determine if someone has a low voltage QRS? There's a lot of different ways that you can do this. One of the ways that I like to look at them is I take and I add up the R waves in lead 1, 2, 3. If it's less than 15 millimeters, that could be a sign of low voltage QRS. I can do the same kind of concept here, but I do it in V1, V2, V3, and if it's less than 30 millimeters, that also could be a sign of low voltage QRS complexes. Why am I worried about that? Well, definitely at the highest point of concern is pericardial effusion. There's something that's blocking the conduction or the electrical activity from getting from the heart to the electrodes. What could that be? Something is blocking the conduction. It could be fluid, pericardial effusion. It could be fat, obesity. It could be air, COPD. Or it could be that the heart is not being able to generate enough of an action potential or conduct action potentials through it. Maybe it's because the heart is really floppy and weak, heart failure. Or super rare, but sometimes if you don't think about it, you can miss it, infiltrative diseases, deposits within the conductive tissue of the heart, like amyloidosis and sarcoidosis. Okay? So big thing to think about here, low voltage QRS complexes. Really be on high alert, especially in the clinical setting of shortness of breath and tachycardia for pericardial effusion. All right, the next thing that I want to be thinking about with QRS complexes is I want to look at the pattern of them as I go from V1 to V6, because it tells me about two different things. It tells me about the R wave progression. Is the R wave progression as I go from V1 to V6 not very good? Or is there a dominant R wave, which is present in the early parts of the precordial chest leads? So what the heck does R wave progression mean? It's very simple. You see how Generally, normally, as you go from V1 to V6, the R wave should exponentially start to really increase. But let's say that it's just only eensy-bincy types of increases that you see as you go from V1 to V6. So it's not a great increase. Usually in V5, V6, those R waves should be pretty dang big. If they're not too big and the S waves are also still pretty big in V5 and V6, and I don't see that nice steady increase going from V1 to V6, that could be a sign of poor R wave progression. And that could be a sign of an anterior MI, or it could be a sign of right ventricular hypertrophy with strain. And we'll look at some cases like that, okay? The next one is a dominant R wave. This is the one that I would be a little bit more concerned with. If I look here and I see the R waves in V1, V2, V3, they're big. And they're not supposed to be really big in V1 to V3. Those are supposed to be small little R waves and bigger S waves. That's a part of the normal kind of cardiac axis there. If I see that they're bigger in V1, V2, V3, and on top of that, I see ST depression, upright T waves, ooh, I'm gonna be really nervous for posterior MI, okay? So that should be at the top of the list whenever you see kind of this dominant R wave in V1 to V3, along with ST depression and upright T waves, think about posterior MI, but make sure you rule out first. Look at old EKGs, do they have a right bundle branch block? Do they have right ventricular hypertrophy and anything that can cause right ventricular hypertrophy? So again, rule those things out first, but be on high alert for a posterior STEMI, okay? Last but not least, for abnormalities with the QRS complexes is, let's talk about what the heck this LVH, left ventricular hypertrophy, and RVH, right ventricular hypertrophy, means and what it looks like. So I look at these, again, similar to bundle branch blocks. I look at V1 and V2, V5 and V6. So again, you have an R wave here, S wave here, R wave here, S wave here. I will add together the height in millimeters of the R wave in V5 and V6, or one of them, V5 or V6, add the R wave in millimeters to the S wave in millimeter in V1 or V2. If when I add those two together, that comes to greater than 35 millimeters, that is a sign of left ventricular hypertrophy. We'll go through plenty of cases on these and pick them out. What could that be indicative of? It could be indicative of any really kind of persistent strain on that left side of the heart, hypertension, aortic stenosis, many different things. Right ventricular hypertrophy, it's the same concept, but it's the opposite. So I look at the R wave. R waves aren't supposed to be big in V1, V2, or V3, right? Particularly V1 and V2. But if my R wave is bigger than my S wave, and I take and I add up the millimeters of my R wave in V1 or V2, and I add it to my S wave, which is not supposed to be big in V5 or V6, but I add that to the millimeters of my S wave in V5 or V6, and that ends up being greater than 10 millimeters, that is a sign of right ventricular hypertrophy. You know what else adds to that diagnosis if you have this? Is if they also have associated right axis deviation, and we'll show you what that means. What could right ventricular hypertrophy be due to? Anything that's putting strain on the right ventricle. If someone has maybe a pulmonic stenosis, or they have pulmonary hypertension due to some underlying lung disease like COPD or interstitial lung disease, things like that could cause some right ventricular hypertrophy. All right, engineers, so in the next part of our systematic approach, we've already covered what? We've covered the rate and rhythm, we've covered the ST segments, we've covered the T waves, we've covered the QRS wave analysis. Now it's time to talk about the QT interval and any abnormalities that may be present there. Why is that important? Well, the QT interval, if it is prolonged, more concerning, it could be something very pathologically, very serious that we need to be able to pick out very quickly. So, first thing we need to determine is, how do we know if it's a prolonged QT interval? Remember, how do we measure the QT interval? You start right there before the Q wave starts to go down, and then you go all the way until after the T wave, okay? And then you measure that distance. Now, generally, we say that QT intervals that are particularly greater than about 460 milliseconds in females is considered to be, definition, long QT, prolonged QT. Greater than 450 milliseconds in males is considered to be, by definition, a prolonged QT. However, to be very, very specific, the computer and you should also use particular formulas. There's a bunch of different formulas, like for example, Bazette's formula, to calculate the corrected QT interval to give a more accurate representation of what the true QT interval is at varying rates. Okay, that's important. So always check your QTC and then utilize those numbers accordingly to determine, is this truly prolonged? Now, Why is this important? Well, the reason why this is important is if someone has a very prolonged QT interval, the concern or the risk is that this can eventually throw them into a deadly arrhythmia called torsades de pointes, which can present as what's called a polymorphic ventricular tachycardia. So we need to be able to pick that out to prevent that from happening. A good rule of thumb is, if you don't want to go ahead and be specific and measure all these things, you can take the QT interval and it should be about half the preceding R to R interval. Okay, so that's another thing to be thinking about. If you see a prolonged QT interval, you've based it upon the QTC, or you've based it upon the half of the preceding R to R interval, you're worried about the risk of developing torsades, what are your differentials that you need to be thinking about that could be causing this? By far, one of the serious ones that you need to be thinking about is there any medications? Because I could quickly just discontinue those. How do I remember them? Antiarrhythmics, antibiotics, antipsychotics, antidepressants, antiemetics. Those are medications that can definitely have a very intense risk on that QT interval, so discontinue those medications. The other things that you need to be thinking about is electrolyte abnormalities. Are they low in potassium? Are they low in magnesium? Are they low in calcium? Because those could be particular things that if we fix it, it'll fix that QT interval. Another really concerning one is ischemia. Is this a sign of ischemia? Is the person having a myocardial infarction? I need to be able to pick that stuff up as well. So once you see a prolonged QT, think about your differentials. If you don't think about it, you could miss it. Rule those things out and treat accordingly. Not as significant, but just to be thorough, we should think about short QT intervals. So what is that defined as? Technically, it's when you have a QT interval that's less than 350 milliseconds. I'm not super concerned if you know this, but for thoroughness, think about it. What you'd want to be thinking about is some of the opposite for prolonged QT. If it was hypokalemia, hypomagnesemia, guess what it would be due to? Hyperkalemia, hypermagnesemia. And on that off chance, sometimes if someone's taking digoxin, some digoxin toxicity could be another thing that's causing that as well. So again, these are the things I want you to be thinking about in your systematic approach here, looking at the QT interval and any abnormalities. Now let's go ahead and talk about the next thing, which is the P wave, PR interval, and any abnormalities present there. Our systematic approach is, what's the rate, what's the rhythm? Is the ST segment elevated or depressed? Are there any T wave abnormalities? Are there any QRS wave abnormalities? What's the QT interval? Is it prolonged or is it short? And now we're at the point where we can say, all right, we have some time. Let's look at those P waves and the PR intervals and see if there's any abnormalities there. What kind of abnormalities should we be looking for and keep our eyes peeled open for? Well, the first thing is you want to be thinking about signs of atrial enlargement, right atrial enlargement, left atrial enlargement, or sometimes even biatrial enlargement. So what does this look like? Well, the first one, let's talk about right atrial enlargement. So right atrial enlargement, what I do is I'll take a look at my P waves and lead 2, and you can even extend this to 3 in AVF if you want to. But I like to look just in lead 2, and I'll take a look at my P wave. Is my P wave a little bit bigger than it should be? In other words, if I look at the height, is my P wave greater than or equal to 2.5 millimeters above the isoelectric line? Because if it is, that is definitely a big P wave, an abnormal P wave, and that could be indicative of right atrial enlargement. To add on to that, to enhance your actual diagnostic skills there, look at V1. So if you look at 2 or 3 AVF, you see a big P wave greater than 2.5 millimeters in height, and you look over at V1 and you see this kind of biphasic P wave where the upward positive deflection is bigger than the negative deflection. That also could be a sign of right atrial enlargement. What else could you do though? You could do an echo and see if there really is some right atrial enlargement. But right atrial enlargement, what could be causes of this? Think about valvular stuff. Is there something going on with the tricuspid valve? It's stenotic. Is the pulmonic valve stenotic? Do they have a lot of strain on that right side of the heart because of something going on with the lungs? Those are all things to be thinking about. Okay? Left atrial enlargement, same thing. Look at lead 2. Do I see a P wave that's pretty big, but more importantly, looks like a camel's hump? It's bifid. If I see a bifid P wave that's located in lead 2, and again, you can send it to 3 in AVF, I just like lead 2 the best. I see a bifid P wave, and the point between those 2 points, the camel hump, is greater than 0.04 seconds. One little box that is considered to be a bifid P wave indicative of left atrial enlargement. To enhance that diagnostic ability though, go to V1. Do you see a biphasic P wave? Oh, I do. So not only do I have a bifid P wave in lead 2, but I also have a biphasic P wave in V1. What's my upward deflection? Bigger than my negative, or is it vice versa? The negative deflection is bigger than the positive deflection in that biphasic P wave. That is indicative of left atrial enlargement, okay? Left atrial enlargement. What could be causes? Think about something going on with the valves on the left side of the heart. Is there mitral stenosis? Is there aortic stenosis? Or is there a lot of systemic hypertension going on that's causing things to back up into that circulation towards the pulmonary circulation, right? So these are things to think about for the atrial enlargements. All right, so now let's talk about the PR interval and any abnormalities that may be present there. So short PR interval, it's less than 0.12 seconds. Again, so 3 small little boxes, okay? If it's shorter than that, that could be indicative of Wolff-Parkinson's-White syndrome. You know, Wolff-Parkinson's-White syndrome does have that shortening of the PR interval. It has a wide QRS. It also has that delta wave as well. So sometimes you may be able to see WPW. Another thing is premature atrial contraction. So sometimes if you have a PAC, an ectopic area somewhere in the atria that fires quicker, and it's closer to the AV node, that may produce a shortening of that PR interval as well. Now these are interesting, but by far what you really want to take away from the PR interval abnormalities is when it's prolonged. Those are the real big meaty ones that you want to think about, especially when it comes to heart blocks. If the PR interval is greater than 0.20 seconds, that is technically the definition of a prolonged PR interval. That's actually one large box. Remember that? One large box. So what do I think about? Definitely if it is long, you want to be thinking about heart blocks. First off is if it's a first degree heart block. First degree heart blocks, they have a prolonged PR interval, but it's the same prolonged PR interval throughout the entire length of the rhythm strip. If it's a second degree heart block, it has to be Mobitz 1, because those also have a prolonged PR interval that gets longer and longer and longer down that rhythm strip. And then last but not least is a third degree heart block. Those have prolonged PR intervals, but they're variable. They could be short at one point in time, but when we say short, they're still long, and then they can be longer. They're all over the place, but they definitely have the ability to have prolonged PR intervals and third degree heart blocks. All right, engineers, so we're at the last part of our systematic approach to 12-lead EKGs, and that's talking about the cardiac axis and any abnormalities that we may be picking up in this portion of the lecture. So at this point, we've talked about rate and rhythm. We've talked about the ST segment. We've talked about the T waves. We've talked about the QRS wave. We went to the QT interval. We even went to the P wave, the PR interval, and all the abnormalities that can come up there. Now we can take a look at cardiac axis and any abnormalities that may pop up there. So we have to ask ourselves the question, what the heck is cardiac axis? So to really make it the basic bare minimum that you really need to know here, let's talk about what normal axis is, okay, normal cardiac axis, and then after that we'll discuss the abnormalities. So normal cardiac axis can be based upon primarily 2 leads within your 12-lead EKG, lead 1 and lead AVF. Now, what you're going to be looking for is using your thumbs to help you in this process. All right, your left thumb is going to be lead 1, your right thumb is going to be AVF. Let's start first off looking at the most important thing, the R wave in lead 1. Is it primarily, is there a positive deflection of the R wave, or is there a negative deflection, a big S wave in lead 1? Let's take a look here. In lead 1, if we were to imagine this is what it looks like, that's the R wave. That's definitely up. So I'm going to put my left thumb up for lead 1. Go here to AVF. Let's look at this first one. Don't mind this for right now. Look at this one. AVF, is the R wave, is our primary positive deflection? Yes. It's both thumbs up. Both thumbs up, that's good. That's normal, baby. That's normal axis. However, you can still have a normal axis in one other scenario. Same thing. Let's say that your lead 1, R wave is positive deflection upwards primarily. AVF, though, there's a predominant kind of S wave. The S wave is bigger than the R wave in AVF. Well, now my left thumb is up, my right thumb is down. That's left axis deviation if your left one's up. But here we got to be very, very careful. If AVF is ever down, lead 1 is ever up, always take a second look at lead 2. The reason why is you base the decision if it is left axis deviation or normal axis based upon the presence of the R wave in lead 2. If the R wave in lead 2 is upright, then it is normal axis. So to recap that part, if you're a positive deflection lead 1, negative deflection, AVF. You check lead 2, and lead 2 has a positive deflection. It is a normal axis, okay? Now, let's talk about times where the axis deviation is to the left, to the right, or extremely to the right. So the first one is left axis deviation. So the electrical vectors are going to be more profound on the left side of the heart, or in this case, left ventricle usually. So what happens is the lead 1, let's use our thumbs here. Lead 1, if there's an upright deflection of the R wave, that's up. AVF, there's a downward deflection of the S wave primarily. That's down like this, right? So that is what seems to be left axis deviation, but what do you always have to check whenever you have lead 1 up, AVF down? Check lead 2. What's lead 2 look like? Wah, wah. It is primarily an S wave, a negative deflection there. So that is left axis deviation. If it was upright, primarily the R wave was up, it would be normal, but it's not. There's a primary negative deflection there. So that is left axis deviation. So lead 1 up, AVF down, check lead 2, it's also down, left axis. What could be causes of this left axis deviation? If you have a bundle branch, particularly a block in that left bundle branch, that could potentially cause a left axis deviation because now the electrical activity has to come from the right side to the left side. It could be LVH, where the ventricles on the left side are thicker and causing more electrical activity to get pushed to that side. Or it could be inferior MIs or hyperkalemia, okay? That is something I want you to think about. The next one is right axis deviation. So use your thumbs again, right axis. What's my lead 1 doing? Oh, that's primarily a downward deflection with the S wave, okay? What's my AVF doing? That's a primary upwards deflection of the R wave. So left thumb down, right thumb up. Which thumb is up? The right thumb, that's right axis deviation. So usually whatever thumb is pointing up is telling you the axis. You just have to be a little bit careful when you do left axis deviation. Check that lead 2. But again, right, lead 1's down, so left thumb's down, right thumb's up. That is right axis deviation. Don't worry about lead 2. You already know it's a right axis deviation. So what could be the problems here? So there could be a right bundle branch block. There's a block in the right bundle branch that's causing the left side of the heart to have to bring electrical activity to the right side. Or there's a thickness of that right ventricle causing more electrical activity to get pulled to that. Or it could be an anterior MI or VTAC, ventricular tachycardia, where the tachycardia is actually originating particularly in the left side of the heart and it's getting pushed towards the right side of the heart. All right, extreme right axis deviation. Extreme right axis deviation, again, use your thumbs here. Lead 1, what's it looking like? Well, there's a primary negative deflection of the S wave. AVF, primary negative deflection of the S wave. Both thumbs are down. Wow, that's pretty extreme, right? So that is extreme right axis deviation. When both of them are pointing down, don't worry about lead 2. What could be potential causes? That right ventricle be thick, right? So thick right ventricle pulling lots of electrical activity to it. That's going to cause an extreme deviation to the right side. The electrical activity, the mean electrical vectors, if you want to think about the QRS vector primarily. VTAC, there's a electrical focus that is maybe developing within the left side of the heart, particularly in the left ventricle, and that electrical activity is spreading towards the right side. Or severe obesity. If someone's really, really obese, it actually can push the diaphragm up and push the heart, maybe the apex, instead of it being towards the left, maybe a little bit midline, maybe even a teensy bit to the right, which kind of affects that mean QRS vector, causing that extreme right axis deviation. So I think this gives you the bare minimum, the big things that you need to know to be able to determine what's the cardiac axis and what could be the potential causes of these abnormalities. All right, Ninja Nerds, I hope this made sense. I hope that you guys did enjoy it. I hope it helped. As always, Ninja Nerds, until next time.